welcome to our Ask the Experts panel about CACNA1A-related hemiplegic migraines. My name is Carolyn Anderson, and I'm the Secretary for the CACNA1A Foundation. We are really glad that you joined us for this interactive discussion and are excited to have two amazing specialists hosting this panel today, Dr. Ingo Helbig and Dr. Shannon Babineau. Dr. Helbig is a pediatric neurologist at Children's Hospital of Philadelphia, where he's the Director of Genomic Science and a core faculty member of the Epilepsy Neurogenetics Initiative Frontier Program. Dr. Helbig previously hosted an educational webinar for the CACNA1A Foundation community explaining genetics of CACNA1A-related disorders, and we are happy to welcome him back. Dr. Shannon Babineau joins us from Morristown, New Jersey, where she's a pediatric neurologist and a board-certified headache specialist. One of the largest knowledge gaps in our community is understanding and the treatment of CACNA1A-related hemiplegic migraines. So we are eager to learn from Dr. Babineau's expertise and extend a warm welcome to her and Dr. Helbig.
Great. Thank you so much, Carolyn, for having us today to speak. And we're both very excited to be able to be a part of this event. So I'm going to start just with a general introduction about hemiplegic migraine as it comes from kind of not necessarily the CACNA1A mutation, although we'll talk about that, but more how kind of it fits into the headache world, into the migraine world, and some just kind of giving you some framework to think about migraine and to think about how hemiplegic migraine fits into that. So let me go ahead and share my slide. So I'm going to talk to you guys first a little bit about hemiplegic migraine, and then Dr. Helbig is going to take over to talk more specifically about the CACNA1A mutation and how that relates to hemiplegic migraine. We're both going to try to keep it at about 15 to 20 minutes max, hopefully, so that you guys have plenty of time to ask questions. So what is hemiplegic migraine? We consider in the neurology field hemiplegic migraine to be a type of migraine that is under the category of migraine with aura. So it's a subset in the migraine category. And so what do we define as migraine? So migraine has been defined as a type of headache that happens repeatedly. So you can see that our medical criteria is that you have to have it happen at least 5 times, although we all know, especially in pediatrics, that you're going to have a first time at some point. So a lot of times we've seen people that don't necessarily meet this criteria specifically, but you have to have had 5 attacks that last for at least a couple of hours, anywhere from 2 to 72 hours of headache attack. And then the headache, the way the headache feels is that's specific to migraine include a couple of things on this list. You'll see that the headache, we usually think about it more in pediatrics as the headache is focal, meaning that the person with the headache can usually point on their head where they're feeling the pain as opposed to the whole head hurting. So you'll ask someone to point where their headache is, and they'll usually point to the front, but sometimes on the side. People that can describe the way the headache feels will usually describe that it's pulsatile, so it feels like a throbbing heartbeat. Not everyone, depending on their age and ability to kind of communicate how they're feeling, can use these specific words, but a lot of times people will say it feels like they've got something kind of pounding in their head. One of the biggest defining features of a migraine is that it's intrusive or moderate to severe, meaning it's not the kind of headache you usually can ignore. It sometimes can start off as a mild headache and build up, but typically people with migraines are having a significant enough headache that they have to stop what they're doing. If the person's in school or playing, usually the child is going to stop even an activity that they're enjoying and want to kind of rest or lie down. And typically the headache gets worse with physical activity, including routine things like walking, bending over, climbing up and down the stairs. In addition, a migraine will typically also have either one of these features or actually both. So a lot of people with migraine, particularly children with migraine, get a lot of stomach symptoms with their headache. Sometimes that can actually be the first feeling that they get, is they'll get nausea, feel sick to their stomach, and oftentimes they will throw up. And then there can also be a sensitivity to the environment, most typically light and sound, but I know some people also get sensitive to smells, to temperature as well. So these are kind of our standard definition of what a migraine headache is. And so moving on from there, what's happening during a migraine that can then lead to this additional type of migraine called a migraine with aura. Just looking through for my definition, we'll go back to those slides. So there's a subset of a type of migraine that's called a migraine with aura. And what's happening there is that there's going to be some other, I usually say a kind of a funny neurologic symptom, although a lot of times it's for the first time it's being experienced, it's more than funny. It can be really scary. It can be very overwhelming for people to experience this. And it usually will be a visual aura. So we will get, the person will describe kind of seeing something, but it can involve other types of feelings, including strange sensations, difficulty with speaking, and then as part of an aura in the subset of hemiplegic migraine, they can get motor symptoms, meaning there can be weakness associated with it as well. So typically the aura kind of spreads gradually and you can have kind of all of these happen in a row. So it can start with a visual aura. So you'll get some kind of change in your vision and then go on to a sensory aura where you get a change in the way your body feels, and then on to speech and language and movement. The typical aura symptoms usually last about 5 minutes to 60 minutes. So there is some variation. There are some people that have something happen just very briefly, and some people it can take a little bit longer to kind of go through that whole process. And then usually the headache is going to come after the aura. Sometimes the kind of first sign that the migraine is coming is the aura. And that's usually how we think about it, that you'll have kind of a change in your vision or a change in how you feel or a change in your strength. And then within about an hour, the headache that we described before for migraine will happen for that person. So what's happening in migraine with aura? In kind of the most kind of broad way that we think about it is that, and we'll talk, Dr. Helbig will talk about this in the genetics section, we think that the brain in a person that's having a migraine with aura is kind of set off this electrical wave. And that electrical wave, as it's kind of going over the nerve cells, is kind of that first thing that's happening in the migraine with aura. So you'll get this spread of an electrical wave as it goes over the surface of the brain, called the cortex. And as it spreads, this electrical wave is called cortical spreading depression, right? So because it's in the cortex and it's going over the brain, then it starts to irritate the surface of the brain, and it changes, it releases all of these chemicals into the brain, and you can see these are kind of symbols of the different chemicals that can get released. And this will change not just it kind of makes it very inflamed. And it can also change the way there's blood flow in the brain. And these are representations of the blood vessels on the surface of the brain. And the combination of this inflammation and irritation on the surface of the brain is what kind of activates certain sensation nerves in our head and what gives us the actual feeling of the migraine pain. So I wanted to show you guys just a couple of examples of what an aura might look like. So this is an example of a visual aura, what someone with a visual aura might experience. Hopefully this will work. It looks like it's working. So you'll start to see kind of a little blind spot. You can kind of see right here. And this is pretty typical for aura, that you get what we call a positive phenomena, or something that's extra. So you can kind of see, if you look carefully, that there's a sparkling colors. So that's kind of as it's kind of activating the brain. And then following it, you'll see it and what we call a negative symptom. So the vision has these extra things in the vision, and then you actually lose your vision in part of it. And it gets bigger and bigger as it moves over the cortex that's responsible for vision, and then it kind of passes through. And so this is just one example of a visual aura. They can be very different for people, and people will describe all sorts of different visual changes. So then I just wanted to give you just a little bit of a picture of where the sensation changes can come. Very typical for people with aura to experience changes in the hand and kind of around the mouth at the same time. And the sensory changes, again, will have that positive and then that negative. People will describe like a tingling, like when you hit your funny bone, and then they can feel a numbness. And it's usually over one side of the body, either the right side or the left side, although it can occur on either side, depending on the different type of migraine. And then I wanted to give one more example of the speech difficulty that people can have with their migraines. So what will often be described is people will say they get their visual aura, they'll see their blind spot, and then they might get their sensory change. And then some people will experience difficulty speaking. They're aware of what they're saying, but the words come out wrong. And this is a woman who's a news reporter who has migraine with aura, and she happened to have her aura while she was reporting at the Grammys. So we'll see if this will play for you guys.
CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go ahead, Terry's in those.
So you can see with that example that she starts to speak and she very quickly recognizes, you can see in her eyes that she knows she's not saying the correct things. And so this is an example of what we call an expressive aphasia, that they're having difficulty getting words out. But when you speak with her and they interview her later at a different point, she's completely aware that she's saying the wrong words, and she knows that it's coming out wrong. So you may, when you see something like this, or certainly if you've been around someone that's experienced anything like this, the first thing that usually comes to people's minds is that the person seems like they might be having a stroke. And so a lot of aura symptoms, including the hemiplegia and the weakness, I think the thing that happens to people first is that they think that they're having a stroke. And so, of course, they go immediately to the emergency room. That is what happened with her. They did an evaluation, and she, developed a headache after this experience. So she was diagnosed with migraine with aura. As I mentioned before, the subset of hemiplegic migraine means that people will get their aura, and usually for hemiplegic migraine, there will be other aura symptoms as well. A change in vision, a change in sensation, like we talked, or speech, and then there will also be a weakness. It usually will involve one half of the body, one side of the body, the face and arm, or the face, the arm, and the leg. Sometimes it can be a little difficult because if your arm or your face or your leg are numb, it's hard to move them. But they're really, people will examine them and look at them, it's not just they feel weird and so it's hard to move them, but a true weakness that occurs for people with hemiplegic migraine. So who gets hemiplegic migraine? In general, it's extremely rare. Even as a migraine subset, we typically quote that about 16% of the adult population has migraine. So migraine in itself is extremely common. Migraine with aura is less typical, and then hemiplegic migraine is extremely rare. This was one population study from Denmark where the prevalence was quoted at 0.01%, so not something that we see commonly. The typical age of onset is somewhere between 12 to 17 years old, but it can happen at any age. And it is seen more commonly in girls and women, which is similar to what we see with migraine. As far as what the prevalence of patients with the prevalence of hemiplegic migraine in those with CACNA1A, I don't know if Dr. Helbig has any numbers with that, but I couldn't find any quoted. So I think that's something that we're not aware of. Typically, hemiplegic attacks will improve with age. Typical triggers for attacks do link with migraine triggers, including emotional and physical stress. And we'll talk a little bit, I think, about specifically with CACNA1A, some other potential triggers to think about that are unique, including things like trauma, head traumas, other things like lack of sleep for women, their menstrual cycle can all be triggers for their migraines, including their hemiplegic migraines. So as far as the types of hemiplegic migraine, we kind of broadly categorize them as either spontaneous or familial. You can kind of see a diagram over here. So at some point, the one person is the original person to get the change in the DNA that causes hemiplegic migraine, but it can be passed on from that point. And then there can be family histories of everyone, different people in each generation will have similar things happen with their migraines. Migraine itself is thought to be a genetic condition, probably because of many different genetic mutations. Hemiplegic migraine, again, as we'll talk about, has some more specific mutations that have been identified and that can be run through families. So there's I think there's 3 accepted, and then there's this kind of ongoing developments as far as other types of hemiplegic migraine. There's kind of 3 types that are all correspond to different genetic mutations. The CACNA1A gene is associated with familial hemiplegic migraine type 1. So sometimes if you're reading about it, you might see type 1 familial hemiplegic migraine. That's what it's referring to. There are these 2 other genes that have been accepted, as well as kind of predisposing people to hemiplegic migraine. And they are often transmitted in an autosomal dominant pattern where there's a high rate where it will go through from the child or from the parent to the child. So you'll see it with a high frequency at every generation. The known types of familial hemiplegic migraine are only a small proportion of cases with people with hemiplegic migraine, meaning that we oftentimes don't find a genetic mutation in people with hemiplegic migraine, even if there's a strong family history of it. It doesn't mean it's not there, and it's probably that there is a genetic mutation that we just haven't been able to identify yet. So we call something a sporadic hemiplegic migraine if the person is the first person in the family to have this type of migraine. But some types of sporadic hemiplegic migraine will have the known mutations that I mentioned before. So they will kind of happen spontaneously. And then of course, sometimes it can be something that will run in the family. We think of treatment for migraine, there's kind of 2 broad categories. There's treatment for the attack of itself, and then there's treatment to prevent the attacks from happening. Because hemiplegic attacks are usually very distressing and can be very problematic. I think I didn't mention here, but oftentimes while we typically think of aura symptoms resolving in an hour, hemiplegic migraine patients will often experience their weakness for many hours or even days or weeks. And so that weakness really sticks around for a while. It takes a while for the brain to recover. And so even if your attacks are not that frequent, they can be very, very bothersome and very limiting if there is weakness associated with it. So we do often talk about preventing the attacks from coming. Of course, we focus on trying to avoid triggers, but even people that are very good at avoiding triggers can't always avoid them. And so medication taken regularly can prevent the attacks from coming. And so there are lots of different preventions for migraine. For hemiplegic migraine, we sometimes veer off a little bit. We don't do always the standard stuff for migraine. So there's a medicine, and we can talk a little bit about why this might be helpful, called Verapamil, which is a blood pressure medicine. It blocks calcium channels. And it's something that seems to prevent hemiplegic migraines from happening. There's a different medicine that's not available currently in the United States. So I do have people that are able to get it from other countries, called flunarizine, that also can work as prevention. And then we sometimes will also use more standard migraine prevention medicines. So you see those listed here. Then there's also treatment for the attack when it comes. A lot of times, especially in the beginning, patients are going to wind up in the emergency room because it's a very dramatic presentation. It's a very dramatic experience to have this weakness. And so a lot of times we do talk about treatment in the emergency room. Doesn't mean you always have to go to the emergency room with your attack, but a lot of times patients are there. And so we do sometimes use medicines for the pain, for the migraine that are listed here. The aura is much more difficult to treat, including the weakness. And so that's, even though that's the more bothersome thing that's happening, sometimes people say even headache isn't that bad. So there are some very small studies or data. So we don't have a lot of information. This is an area that is something that we're still learning about in medicine. But there are some options for treatments, again, not just for the pain, but for the aura, to try to help with the aura symptoms. There's also some things that we avoid. There are some medications, and if you have questions about this, I'm happy to talk about why. There are migraines that you may, if you have migraines or you have a friend with migraines, they might mention a migraine medicine to treat it, and we sometimes will avoid them in people with hemiplegic migraine. These are medicines like ergotamines, triptan medications, things like that. So I'm going to stop there, and I'm going to hand over the speaking to Dr. Helbig so he can talk to us a little bit more specifically about CACNA1A mutations in hemiplegic migraine.
Perfect. Thank you, Shannon. Let me just see whether this transition works. And let me just double check. Can you see my screen?
Yes.
Yes, we can.
Perfect. So I will talk about hemiplegic migraines in the context of CACNA1A. And I would like to maybe start by thinking about what the kind of conditions are we're talking about. So when I had the luxury today to kind of, or the honor today to be part of the entire meeting. And so I kind of took some screenshots of some of the other presentations. And at the top, you can see one of the screenshots that Terry made, or that one of the slides that Terry had about the hemiplegic migraine variants. And at the bottom, you can see this kind of lollipop plot from Wendy Chang's registry. What is clear is that when we talk about CACNA1A and hemiplegic migraine, very, very often, we're not talking about mild familiar conditions where individuals have headaches and they have auras and they have a pure FFHM. We're almost exclusively talking about severe hemiplegic migraine episodes. At the bottom, you can see the most common variants in the CACNA1A registry are the V1393M and the R1349Q, and those are severe neurodevelopmental disorders. And what I typically share with my families as a kind of child neurologist is that these conditions are a different category to the typical hemiplegic migraines, and calling them hemiplegic migraines often feels wrong. Yeah. So I would like to introduce CACNA1A related HM or hemiplegic migraine in the setting of neurodevelopmental disorders, of a kind of complex interplay of features that have 4 dimensions: developmental delay and autism, ataxia, epilepsy, and hemiplegic migraine. And this is our look from the pediatric perspective, especially from the pediatric perspective from a kind of large teaching hospitals, where we often are the referring center for children who have kind of unusual conditions. And in this setting, in all these 4 dimensions, hemiplegic migraines are often the most mysterious and the most difficult to treat and the most difficult to prognosticate neurological features. We understand developmental delay autism, we understand ataxia, epilepsy, we have a good handle on how to treat this, but hemiplegic migraine is often the big unknown. I want to introduce my lab and my group quickly. So I'm a child neurologist at CHOP, Children's Hospital of Philadelphia, and I'm one of the attendings and directors of our epilepsy neurogenetics program. And I clinically see patients with CACNA1A in my clinic, and often when we have admitted them also in the on the ward or in the intensive care unit. My research that I'm going to just kind of mention briefly on the side is mainly in genetics and data science. And here's just kind of one snapshot from my lab. We try to understand disease histories and natural histories in some sort of an alternative way. So we try to use computational tools, large data, big data, try to understand how can we make sense of existing data to understand natural history. I also took a screenshot of Tracy's slide, and this is actually, she presented a slide that was from one of my publications. So I have this like a double mirror screenshot. And she made this kind of comment on the side that CACNA1A is not on this time graph, and it is not on there for a reason. So we didn't put this on there for a specific reason. And the reason is that CACNA1A has never been a clear epilepsy gene. It was clear from the very beginning, from the very early discovery of CACNA1A, that this is a more complex gene and there are many more features. So let me maybe start my presentation and tell you what I would like to talk about. I'd like to talk about what is CACNA1A related hemiplegic migraine. And since this is a kind of a mouthful, I'm going to shorten this to CHM, CACNA1A related hemiplegic migraine. I will talk about the presentations of these severe CACNA1A related features in the pediatric setting, which can be a neurological emergency. And finally, I will kind of talk about concepts for treatment and prevention. I'll talk about general principles that we'll discuss with our patients and give you an idea of how we often combine epilepsy and migraine treatment. So many of these kind of strategies that Dr. Babineau also mentioned in her presentation, how do we kind of apply them to children who have these combined neurodevelopmental features and hemiplegic migraine episodes. So let's start by kind of saying what is CACNA1A related hemiplegic migraine. And this is maybe a different presentation of what you've seen previously in the other presentation. So there's a mild end where we have what I would call common hemiplegic migraine, even though Dr. Babineau just kind of, I just learned from Dr. Babineau's talk that this is even in the migraine population extremely rare. Yeah. So this is the kind of hemiplegic migraine, and you can see at the bottom a woman who has a weakness, and then this weakness goes away. And then on the other end, here you can see a child who has a CACNA1A related hemiplegic migraine to one of these recurrent gain of function variants, who has a severe life-threatening brain swelling. And again, I'll introduce CACNA1A hemiplegia or hemiplegic migraine as one of these dimensions of this complex neurodevelopmental disorder, as one of these features that I would like to set apart from the developmental delay, from the ataxia, from the epilepsy, even though this is often interlinked. And again, among these various dimensions, among these various features, this is often the most poorly understood feature. This is what kind of causes families the most amount of anxiety. And this is often a kind of feature where we would like to provide more information to make sure that we can catch attacks as early as we can and kind of treat them adequately if they happen. Let me introduce this by saying who is at risk for hemiplegic migraine within the kind of broad range of CACNA1A related disorders. And what I would maybe say first is that CACNA1A is not a single disorder. CACNA1A is a condition where the clinical presentation of an individual often really depends on what the mutation is. So for every family, for every affected individual, it is important to understand what exactly this mutation is, and if this mutation is either a loss of function or a gain of function. Individuals with loss of function variants have developmental delay, ataxia, nystagmus, PTU. This is often a constant feature. Sometimes we have features where we're not quite sure, is this an episodic ataxia or is this just an exacerbation of an underlying baseline ataxia? And as far as we know, individuals who have a loss of function variant do not have a known risk for hemiplegic migraine. And this became clear also in the previous presentations. Hemiplegic migraine is a feature of gain of function variants. When an individual has a gain of function CACNA1A variant, this can be a very mild gain of function variant, which is quite rare. Yeah, those are these kind of milder hemiplegic migraines. But what we see more frequently are children who have early onset epilepsy, a feature that we call epileptic encephalopathy, and you'll hear about this tomorrow in the epilepsy section. These variants are often recurrent, so those are variants that are seen in more than one individual. And some of these presentations may be quite specific on what the specific variants is. And some of these gain of function variants may lead to hemiplegic migraine. Here is one of my kind of older cartoons that is on my blog for the CACNA1A protein. And the recurrent CACNA1A variants that often lead to hemiplegic migraines is the 218, the 1349, and the 1396. I'd like to mention at this point that in our session on how to read your genetic testing report, we pointed out that sometimes in older testing reports, these variants are named differently. You know, so if you have any question and you realize that your variant or your child's variant is not on there, it might make sense to kind of talk to your provider and see maybe this variant has been renamed, or maybe there's a different way to describe this, or is there new additional information. So how, in a pediatric context, how do these severe hemiplegic migraine features present? And I would like to maybe delineate the extreme end of what is happening. So Cagnon-A-related hemiplegic migraine episode, they can be a neurological emergency. So severe hemiplegic migraine, those are events with sudden neurological deterioration. They can be provoked or unprovoked. Head trauma or mild head trauma may often occur. They lead to obtundation, sometimes coma. They are often associated with hemiplegia, but not always. And hemiplegia may only kind of occur afterwards. They may result in refractory seizures. So this is a sudden brain event where seizures may get worse or may kind of happen for the first time. And this may result in brain swelling. Yeah? And when we think about the severe Cagnon-A related hemiplegic migraine symptoms versus the kind of milder hemiplegic migraine, we know that there are some shared features, but the clinical course, the intensity and the amount of therapies we have to give children is drastically different. You know, this is, sometimes I call this a dangerous misnomer, because hemiplegic migraine sounds very mild. It sounds like a condition that we can handle outpatient, but these events occasionally can be life-threatening. Yeah? And sometimes we feel that they're more similar to epilepsy than the common mechanisms in migraine. So here is one example that is kind of published in the literature that I wanted just to use because it shows some of these features. So this is an example of an 8-year-old boy who has a 1349 variant, a PR1349Q variant. And this boy has developmental delay, ataxia, and repeated episodes of coma after mild head injury. This boy also had seizures. And when you would like to kind of understand where do these different features come from, this is an image of his brain. This is an MRI image. And when you look at the top, you can see the two parts of the brain. We call them hemispheres. And you can see that the part on the left, which represents the right side of the brain, this is always kind of flipped around on these images, is a bit swollen. You can see these kind of white lines, which represent water. They're kind of a little bit less. And you can see this is a bit more fuzzy. And this is a brain swelling of brain edema. This is what causes the reduced alertness, the obtundation, the coma, and this causes seizures. And at the bottom, you can see the cerebellum. This is the part of the brain that is important for coordination. And this is what has caused this child's ongoing ataxia. You know, ataxia can be linked to kind of hypotonia or can be linked to nystagmus, but this is the kind of causative feature here. So this is a presentation of a CACNA1A related severe hemiplegic migraine. And again, you can see this has very little to do with migraine. Headaches and kind of auras are not a major concern for these children. Those are coma episodes that can be dangerous because brain swelling is a critically severe condition. Let me continue by talking about a few considerations when it comes to some of the things I kind of picked up today during the conference. So first of all, it's important to kind of name the episodes correctly. I've heard the kind of word alternating hemiplegia being used today, and this is actually a different disease. And it is important to keep this apart. So alternating hemiplegia is a different condition due to a different gene, and this is different from hemiplegic migraine, even though it often sounds the same. Hemiplegic migraine is extremely rare, and Cagnon-A related hemiplegic migraine is even less common. So many of these features often may only be correctly identified afterwards. Yeah? Some of the Cagnon-A related hemiplegic migraine episodes may neither have headache nor hemiplegia. We just kind of name them like this because this is the historical convention. And when it comes to kind of educating families or making families understand what events are, it's important to know that hemiplegic migraine episodes are not fast or subtle. They are often always prolonged, and those are not episodes that families would typically miss. One of the naming conventions that we have with hemiplegic migraine is historical. And this is due to the fact that Cagnon-A was first discovered in families with ataxia and with hemiplegic migraine. But as I mentioned earlier, Cagnon-A disorders are more than one disease. They are Cagnon-A related mild hemiplegic migraines, which we would really kind of call as familial hemiplegic migraines, but those are not the conditions we would see in a pediatric setting, and those are not the conditions that kind of cause us the most concern. And especially in 2021, the severe Cagnon-A-related hemiplegic migraines, they are more frequently recognized. We do more testing, and we recognized children more early. Yeah, and again, let me kind of go back to my slide here and think of this as kind of 4 different dimensions how CACNA1A can present, and that the hemiplegic migraine dimension is the topic of our talk, because this is the kind of most poorly understood feature here. So let me give you a few more important considerations. When hemiplegic migraine episodes present in CACNA1A, these episodes, especially when they happen for the first time, they're almost always unusual. Yeah? There's often a delay in recognition and diagnosis, and especially when this happens for the first time, and an individual may not be diagnosed with having CACNA1A yet, it is basically impossible in a setting of an emergency room or an ICU to really be completely sure that this is a hemiplegic migraine episode and not a stroke or not an infection. This often will become clear over the course, but this often kind of explains some of the confusion and some of the disarray that sometimes goes into making this diagnosis, because for everybody who sees this, this is an incredibly rare and an incredibly intense neurological presentations. A hemiplegic migraine episode may progress, and in some individuals, this may be different from other episodes. So just because an episode has been mild in the past, we often kind of see that there's some stability in how these episodes presents, but when it comes to the intensity of an episode, whether this kind of causes obtundation or seizures, this may often be not as clear unless we really know this well. When it comes to recovering from hemiplegic migraine episodes in the setting of CACNA1A, again, I pointed out that those episodes can be life-threatening. Brain swelling is a condition that can be extremely dangerous, and this needs to be treated in a medical setting and not at home. Yeah? And many individuals need weeks or months to actually recover from the initial attack. Hemiplegia, so the weakness on one side of the body, may get better over time. And sometimes we see a good outcome, even though initially the brain swelling or the brain scan was very concerning. When it comes to the prognosis of hemiplegic migraine episodes in the setting of CACNA1A, often the question that we get from families is, if and when does the next episode occur? And this for us is very difficult to predict. And this is more difficult than in the setting of seizures or assessing how severe an ataxia is. So what we recommend is that every individual who has a Cagnon-A-related hemiplegic migraine has some sort of an action plan that makes sure that treatment is initiated urgently. Yeah. When it comes to the overlap of epilepsy and Cagnon-A-related severe hemiplegic migraine, they often coexist. The episodes themselves may result in acute seizures, and they may often result in seizures that are extremely difficult to treat, that require IV medication in an intensive care unit. And many individuals already had episodes of seizures or a diagnosis of epilepsy before this. And this is something that we often think of as a kind of complex relationship. So both kind of are coexisting, yeah. And it's important to kind of treat this adequately and early. And if a child or an individual has epilepsy and hemiplegic migraine episodes, we often like to use combined treatment strategies, so medications that work for epilepsy and that work for migraine treatment. Let me kind of tell you the kind of last part about my slide about how do we treat and prevent Cagnon-A-related hemiplegic migraines. And I would like to break this down in kind of 3 different categories. And the categories are what to do at home, what to do in the emergency room, and what to do in the hospital. And of course, often what is happening in an emergency room or in a hospital is not really something that we have complete control over, because there are many different decisions that kind of go into this. And this may be very different from child to child. But typically we say, when we think about action plans, we want to educate families that we would like to treat these hemiplegic migraine episodes as soon as possible. Both migraine and seizures have underlying biological mechanisms that kind of feed into each other, that get worse over time. And I always think of them as a bushfire. You saw these kind of cartoons or these kind of images of cortical spreading depression, and we know the earlier we act, that the better we can treat them. And then typically we would ask our families to talk to their providers to have an action plan at home, and this may include the kind of classical hemiplegic migraine treatments, verapamil, Diamox, epilepsy treatments, so sometimes benzodiazepines like Diastat, and sometimes even pain treatment. When these episodes either have been shown to be responsive to pain medication, or we think that the child is actually in distress. In an emergency room, we always recommend that the family has a letter from the provider that says an individual has a Cagnon-A-Related hemiplegic migraine. This is extremely important because this kind of really helps the ED staff and the emergency room team to really understand what is going on. Often there may be a need for EEGs or brain imaging, and then there's specific IV medications, steroids or verapamil that can be given if this is kind of required. In the hospital, it really depends on how sick an individual is and how long these episodes are. But what we've seen is that it often makes sense to kind of observe an individual for maybe 2 to even 3 days. And the reason for this is that there are some reports that CACNA1A related hemiplegic migraine episodes can be mild initially and then get worse over time. They're not going to get worse after 5 days or after a week, but they may be initially partially treated, and then there's some dynamics in the disease process that really only manifests after a day or so. So this is something that's for kind of families to know that it's important to have at least some observation time to make sure that everybody is safe. What are additional important considerations? So even though they often look like a stroke, hemiplegic migraine episodes are not a stroke. The prognosis, even after a very severe episode, is different from a stroke. So if you had a stroke and the size of the brain swelling, this would kind of result in the entire part of the brain being non-functional or destroyed. And this is not happening in CACNA1A to this extent. However, the brain swelling in CACNA1A can be more severe than we would see this in stroke. And often you will have the discussion with your doctor that basically in many instances, unless this is very, very clear, it is very important to rule out other causes. It's important to rule out, is there an infection? Is there a true stroke that just kind of masquerades as a hemiplegic migraine? And this is often a very intense and workup that we need to have for hemiplegic migraine. When it comes to treatment, every child or every individual is different, and there's not really one size fits all. So when we looked at the described treatments and the treatments that we would like to do, we often have an individualized therapy, even though we have like general principles, and there are no kind of controlled studies for CACNA1A yet. When you look at the literature, the drug response in patients, even with this very same variant, may be vastly different. So it is not the case that every child always responds to verapamil, or that we should never give epilepsy medication. And it is often important that we have a hard time telling apart whether the features we see are a drug response or is part of natural history and this kind of very dynamic evolution of hemiplegic migraine symptoms. Typically, time tells an individual patient, but I'm just bringing this up because when we read the literature, we sometimes see vastly different responses that have been reported even with patients in the very same variant. So knowing this, what are some general principles that we can use for preventive treatment? So I typically think of treatment of hemiplegic migraine in the both urgent setting, at home, emergency room, and in the hospital, and in the kind of outpatient setting. What do we do to prevent then the next episode in 2 different streams or in 2 different pathways? So one part is the kind of epilepsy pathway. This may or may not be relevant depending on how severe these episodes are. And the other one is the kind of preventive migraine treatment. So what are the medications we would typically use for migraine? And when I kind of put my talk together, what I thought would be in a way to kind of explain this is this little box. So I would call this the kind of treatment matrix, where we think of this as these 2 different streams. We have the migraine treatment, the familial hemiplegic migraine pathway, and the epilepsy treatment, the kind of seizure pathway. And here we have these kind of 4 different situations. We have the prevention treatment, then we have the treatment of the acute episodes, both for seizures, both for kind of the migraine itself, with these 3 questions: what to do at home, what to do in the emergency room, and what to do in the hospital. I'd like to use maybe 2 minutes just to introduce the kind of research side of our activities. So my lab at Children's Hospital Philadelphia has some CACNA1A links, and our main 2 links right now is that we're part of what is called the Center Without Walls, which is a large project in the US to look at ion channels, and we've kind of started cataloging and analyzing CACNA1A variants as part of our activities. We've been pushing for this for 2 years, and we kind of finally cut our way that we can actually study CACNA1A as well. And our research in my own lab mainly kind of deals with computational tools to analyze patient data, genomic data and clinical data. And we kind of mine data from electronic medical records. We kind of build framework to connect clinical data points. You've heard a lot about kind of patient registries and kind of medical data aggregators like RareX. And what my lab does is kind of take this information and say, what does this actually mean? How can we kind of get knowledge from this? How can we harmonize data? How can we kind of build structures to compare different data sets? How can we build algorithm computational tools that help us understand outcome? Here are a few kind of screenshots from our work. At the top left, you can see tools that we've kind of built at our center right now that kind of systematically look here at seizure frequency. We also have done this for headaches with some of our colleagues, and where we know, and this basically shows you different categories of seizures. Red is daily seizures, green is seizure-free, how patients kind of change in their seizure frequency. And the top right, you can see some of our kind of tools that translate patient features into kind of standardized and computable terms. We're rebuilding dictionaries that allow us to kind of capture more information for patient. And at the bottom, and on my next slide, those are basically our information we have on CACNA1A right now. So this is kind of looking at our medical records in roughly 700 patients with kind of genetic epilepsies, a very broad range of patients. Then we can ask the question, how does CACNA1A stand out? What features do we see in CACNA1A over time? And this is often built on very large data points of kind of hundreds, sometimes hundreds of thousands of different points. And we hope this would kind of help supplement some of the kind of clinical data and kind of help understand CACNA1A over time. So what I was trying to do in my presentation is to kind of talk about CACNA1A related hemiplegic migraine, talk about the presentations and the treatment. And I would like to kind of finish with 2 thank you slides. This is my lab, yeah, we're in the Roberts Center at CHOP, which is where our computational lab is. And then I'm part of what is called the CHOP Epilepsy Neurogenetics Initiative, where we have now 10 neurologists and epileptologists who almost exclusively see patients with genetic epilepsies. We're kind of supported by a large staff of genetic counselors. And in our prior presentation, Lena Lusk has been my kind of partner in crime, who kind of does our CACNA1A studies. And then we have a large support team of physical and occupational therapists. And then I'm happy to take any questions.
Wonderful. Thank you so much, Dr. Babineau and Dr. Helbig. We really appreciate all of that information. We are going to go ahead and move to the Q&A portion here, and we do have quite a few questions that have already come in. The first one that we're going to go to is from a CACNA1A parent, and she would like to know, how would an aura possibly present itself in a nonverbal, non-ambulatory child?
I think that especially in related to this genetic mutation, I think a lot of times for some of these episodes, it's not necessarily going to be something like it would be more of a change in their behavior, their level of awareness, because as Dr. Helbig was mentioning, you can have more profound, become more confused or not as alert. So I think that's one possibility. As far as the weakness, you would, I think, still be able to see sometimes in facial movement. It's not moving the equivalently on both sides, and depending on movement in the body, that there will kind of be more weakness there. But other types of aura, I think, would not necessarily be able to be characterized.
Our next question, we're going to go ahead and call on Louise Crow Swords. Louise, if you want to unmute, you can go ahead and ask your question.
Wow. I have a question in that I have a 32-year-old son who he's had his, Dr. Samponi did his, recreated his variant, and he is a net loss of function is what I'm understanding, but he does have gain of function in there. So he's a combined guy. He presents with, his diagnosis is FHM1. And I guess I'm wondering how all of that fits together. He's already going against what Dr. Helbig has said about gain of function being the hemiplegic migraine. My son's original diagnosis was cerebellar ataxia with cerebellar hypoplasia with ataxia. And I guess I'm confused, and I'd like you to further explain how he can be both and not fit the one category that one person says he's got, and how do we treat that? And I also believe that he's morphed into a different hemiplegic migraine aura. He used to be what would be called classic all of his life long. We didn't know what it was that was going on. So he was in a coma in a hospital being observed for many times as a youth, but he was not medicated at all.
Yeah.
He was treated with Tylenol, ibuprofen, and Gravol, because that was the mom thing that I could do to help pain and throwing up.
Yeah. Yeah.
And the hospital offered nothing.
Yeah. So Lisa, so I'm first of all, I'm very sorry to kind of hear your story. I think you're very this is often a very kind of difficult journey that kind of families go through. And I think what you're giving us an example of is basically the kind of different names that sometimes hemiplegic migraine kind of goes by. The way I would address this is leave the functional studies out for a minute. You know, what I think from what you've kind of described from the kind of clinical presentation is not that much different from what many other kind of Cagnon-A hemiplegic migraine families have been going through. Repeated episodes of coma, ataxia is common. Probably your son also has some developmental issues, I would assume. Yeah, this is a kind of a typical presentation.
He's globally developmentally delayed,
yeah,
yes,
yeah.
and he's
So
he's had a regression in the last 10 years.
Yeah. So this is a kind of is not that much different from some of the kind of clinical presentations that we've seen. I think what is often different is the kind of labels that people attach to it. You know, often we kind of say this is a FHM1, then everything that we see on the literature we think must apply, and then it doesn't really fit, or this is a cerebellar ataxia. So those are, I would think of points in time. You know, and what is very difficult, or what has been very difficult for us, especially in this kind of Cagnon-A field, is that there are often labels attached or words that are being used that don't quite fit. Yeah. What I think you're describing is a kind of a relatively typical presentation of a Cagnon-A-related disorder that we would call severe hemiplegic migraine. These kind of coma episodes are what doctors often call hemiplegic migraine episodes, even though they may not be related to kind of having hemiplegia, even though they may not have been kind of headaches. But this is the kind of classical kind of terminology, or this is the kind of classical language that the medical community uses for this. When it comes to functional studies, functional studies often don't. So the way I would think about this is the kind of clinical features that a patient has always tells us more about what the kind of mechanism is than what a kind of a functional study would necessarily do. We see this in many ion channels that some mutations have what we call mixed properties, so that they're neither pure gain of function or loss of function, and how a certain kind of property of this mutated channel then actually represents in the clinical features is often hard to kind of really examine in these limited test environments that these experiments are kind of done in. It's not quite clear what part of these kind of, we call them biophysical parameters, what part of these changes result in these kind of hemiplegic migraine symptoms, whether there's a common thread to this, but it is kind of absolutely common that many of the mutations that we see have some mixed features, and then often some of the symptoms may be more aligning with the gain of function components rather than the loss of function. Yeah, I might want to, if this is okay, I might also want to kind of, when I was just talking about like naming episodes and naming features, I think there was a question coming up, a kind of alternating hemiplegia and hemiplegic migraine. And I might want to maybe just conclude this quickly by saying alternating hemiplegia is a name of a disease. This is not a name of a symptom that a child has, even though this may be a weakness on one side and in one episode and weakness on the other side. Think of alternating hemiplegia in all caps. This is a kind of condition that's called AHC, and this is a kind of distinct genetic disease that is called alternating hemiplegia of childhood that is due to a different gene. So this is not something that a child with CACNA1A has, but it is a name of a different condition, like familial hemiplegic migraine is linked to CACNA1A. I'm going to kind of post the link to the National Organization of Rare Disease, AHC, page into the chat, just to kind of inform you that this is kind of when people talk about this, they're not talking about a child who has episodes on the left and then on the right, and it has a CACNA1A change, but this is a kind of name of a separate condition.
That's interesting. I didn't ask that question, but that is interesting because my son was back and forth. We couldn't pinpoint his side. Now it looks like it's all on one side, but
yeah, no, he had this case. He would have had events that alternated, but alternating hemiplegia is some kind of a term that people use for one distinct disease.
Great, thank you for that question, Louise. We hope that that's helpful. Thank you, Dr. Helbig. Our next question is, we're going to go to Katie Brennan. If you could unmute and if you want to start your video.
My question, my daughter has 1349, and had 2 severe events. My question is, I know that you say it's not stroke, but is stroke possible? My daughter has lasting deficits on her imaging and can't use her right arm anymore or drink liquids, lost speech, and it's been years. So is that ever possible?
So Katie, I'm very sorry to kind of hear this. This is something that is possible, unfortunately. So when we think about stroke, or when we use the kind of common term of common kind of use of the word stroke, we think about a kind of blockage of a big brain vessel that leads to a part of a brain not being supplied with oxygen and with blood. We know sometimes when episodes in patients with severe Cagnon-A-Related hemiplegic migraine, it result in severe swelling. There can be some lasting injury. This lasting injury is often the cause for the kind of weakness and for the atrophy that we see. But there are also episodes where this does not happen. Where this happens in some cases and not in all of them, it's often not known, and it's probably related to the severity of the episode.
Okay, so thank you for that. And then I wanted to ask a question. Her 2 events, it alternated sides that were affected. Do you ever see that?
The way that you can think about this is that the CACNA1A mutation is basically in the entire brain, and there is no reason why this would be on one side or the other side. I don't think that anyone ever kind of really looked at this on a larger scale where this is more happening on one side or the other side, but it is common and it has been seen that this may happen on one side and then on the next side in the next episode. Disease, it is not a kind of an injury that is in the brain where this would always happen on the same side, but this may happen alternating on both sides. And again, just to point this out, this is not alternating hemiplegia. It's just, it may happen, those are hemiplegic migraine episodes affecting the left side or the right side.
Okay, and then my last question was, what is the dosage guide for Verapamil for Preventive? Is there one?
I would maybe just kind of defer this question, because what I always try to do then is really make very clear recommendation in terms of treatments really kind of depends on what a child, how old a child is, what other medications we have. Yeah.
Is there something I can refer to my physician about that, or is that common knowledge?
Shannon, I think that there's some kind of guidance in the headaches literature on what dosage we would typically recommend, right?
Yeah, there are kind of standard, and again, this doesn't come from even hemiplegic, it can come from hemiplegic migraine in general, not specifically to this genetic mutation, but there are kind of dose ranges for younger patients. It's based, and even adults, at times it's based on weight primarily, but there's also a range within that. But it's something that I saw a couple of things that I'm trying to work with the foundation to come up with some information for families to have to be able to present to their treating physician or in emergency rooms, so we can I can go back and do put some more specific stuff about dose ranges if people think that would be helpful. So there is some guidance there, but it's going to be unique to the person too.
Yeah.
A little bit on the heels of that, we had a similar question regarding dosage, but also, is there any information that when our families show up potentially at the emergency room, is there any literature or something that we would be able to hand them, or something that they can reference to, cite their CACNA1A variant and how they might go about treating a hemiplegic migraine?
Yeah, so I would not give them literature, because I would ask I would suggest that families discuss with their neurologist to have an action plan. So this is very common both in the epilepsy and in the migraine field, that we have some sort of a kind of action plan that families have, and that almost plays through what would happen in this setting of an episode. Yeah? And especially when this kind of term, when this letter says this individual has CACNA1A, this is a one-page letter that your neurologist could provide you with, that gives some kind of general guidance of what you would do. Yeah? And this is often it's often just important to kind of reorient the kind of emergency room team that this is not just a migraine, that we would not be very concerned for a stroke, even though we have to rule this out, but this is a kind of hemiplegic migraine. So emergency room letters is would be my main answer to this.
Okay,
and again, we kind of know this from many other rare genetic diseases, some sort of a patient letter that kind of says, this is what this child has, and that is kind of signed by your neurologist, is often very good in the emergency setting. Yeah. Because then it kind of, then the family doesn't have to be the translator. Yeah? Then it's basically, it's a document that often kind of helps reorient this, and just kind of helps kind of guide the care.
Okay, great. One of our next questions is there a known association between CNS autoimmunity and CACNA1A mutations, and can autoimmune deficiencies trigger CACNA1A-related hemiplegic migraine episodes?
Not to my knowledge, no.
Okay, thank you. Our next question is, can CACNA1A gain-of-function individuals who experience hemiplegic migraine episodes expect to see cerebellar atrophy, and how would this potentially affect them long-term?
So I would think of this as two different things. So cerebellar atrophy and ataxia is common across the entire CACNA1A spectrum. So this is kind of one of the features that individuals with loss of function variants and gain of function variants often have in common. Cerebellar atrophy in CACNA1A is often slow and progresses over time, and is often more a reflection of the underlying ataxia that an individual has, and not something that is kind of found accidentally. So this is something that often is imaging, is, if this is only when it comes to the ataxia, is often reflects the amount of ataxia that a child has, rather than being prognostic of future severity of ataxia.
Okay, thank you. One of our next questions is, can you explain if Tryptans are contraindicated for treating hemiplegic migraines? And are there rescue medications that you can recommend? One in particular we had a question about was Ubrelvy, and I might be saying that wrong.
So as far as treatment, I think that for kind of, as I mentioned briefly, I think for a long time, because patients with hemiplegic migraine from the migraine world were excluded from trials, and kind of in a previous understanding of these conditions, there was concern about risk for stroke. Now we're talking about how we think that that's, as we learn more about the genetics of that seems to be less of a concern. But because traditionally patients with hemiplegic migraine were not involved in those trials and those concerns, kind of traditionally we leave triptans out of the treatment protocol for that concern. Now, it may not be founded with regards to kind of what's truly happening to the brain as we get better understandings from a genetic standpoint. However, it's my practice, because especially in pediatrics, we tend to be much more conservative with treatment, at least to start, that I try to, I think because it's not been looked at, and they're still, they kind of have not been used with any high frequency, I tend to avoid them. I don't think that's necessarily, at this point, I think if you have someone that really has tried several other types of medications, it's possible it could work. But again, the triptans were designed for kind of more traditional migraine, and don't necessarily always work for the pain related to what would be happening in this form of migraine, whereas other kind of stronger anti-inflammatories, things that are in Motrin, but other things that you can give through an IV, as well as things that are working on kind of more specific to the genetic mutation. And the triptans, I think, it's not as clear that they would help, even if you did go down that route, doing something that we haven't done, so we don't have a lot of experience. I don't know how helpful they would be based on their mechanism of action. Ubrelvy is a newer medication for migraine that kind of works in a different pathway than the triptans do. And again, I don't know, part of what it's targeting is the inflammatory change in a different way that happens with traditional migraine. I don't know if it would work. But I think there's less of a concern as far as kind of making a lot of modifications in the vasculature. So it's something that could be there, but it's very new. So we don't even have, we just have it as an approval for those that are over 18, and there are ongoing studies and using it in pediatrics, but it's not, it's only come out in the last year. So again, it's something really, it's a new medication and something that we have very little data on just in the general migraine population. So it's hard to kind of use it again in this more kind of specific area. Not that we can't, as we learn more about it, think about it.
Okay, thank you. And a little bit related to that, we have a family that's in Scotland who submitted a question prior to this event because their son experiences very severe pain during his hemiplegic migraine episodes. And they wanted to know if there was any other pain medication recommendations that you might advise that they explore.
I think there are many different kind of traditional like the non-steroidal anti-inflammatories. So that's what Motrin is, or ibuprofen is a category of. But there are mechanisms that are slightly different amongst all of those. And I have found that sometimes if you cycle through a couple of them, they're usually prescriptions, but that you can often find some benefit, as well as kind of looking at different delivery methods, as opposed to, again, ibuprofen is traditionally orally, right? So taken by mouth, there are delivery mechanisms that are nasal sprays, and even I have had people get trained in administering it as an injection, or certainly you can go to, when you're in the emergency room, it's given through an IV, and so it's more effective in a more rapid way. So sometimes just changing the delivery system of those kind of more traditional medications. And then we often will use medications that are kind of old migraine medications, but they have kind of broad, they work in many different pathways, and some of them we're probably not even sure exactly how they're working. So we often will combine our non-steroidal anti-inflammatory with, they're kind of categorized as anti-nauseants, medicines for nausea, but they also have pain relieving techniques. So these are medicines that go by the name like metoclopramide or prochlorperazine. So you may have heard of them as a nausea medicine, but actually they are pain medicines as well. And these have been studied to try to help. So I think often, and usually you need a combination of things. It's often not going to be just one medication for these attacks. It's often going to be a combination of things. So usually I will start with a non-steroidal as well as these kind of anti-nausea medicines. And then I have added things on from there, but that's usually kind of my basis from a treatment standpoint, and then from a guidance standpoint for pain in the emergency room. They're kind of more, they're kind of, again, it's all kind of experimental, but smaller case reports of some other types of medicine. There's a medicine called Ketamine that comes up a lot. That is a kind of a pain medicine that works on different types of receptors that's different than these other two medications, that sometimes is talked about as managing both the pain and the aura, right? Because the weakness as possibly as well. So, but those are some thoughts.
And so maybe just Shannon, to add from mine. I mean, this is the reason why I think many of these protocols are often individualized, because pain may be more of an issue in some individuals than in others, even though they may actually have the same genetic variant. And I think this is why I like families to think about this kind of dual approach of treating this as if this was a severe migraine, to have this kind of preventative strategies. And I've heard at least of a few situations where some of these anti-nausea medications have been abortive, so they kind of actually stop these episodes. But I think it's always good to have kind of a parallel plan to say what happened if this episode progressed and really resulted in this kind of obtundation, coma, seizures. But this again is very individual per the patient, how old the patient is, what specific mutation this is, and how severe these symptoms typically are.
Thank you. One of our other participants would like to know if a patient is taking Verapamil, should they be followed by cardiology? And you guys also mentioned that Verapamil is used as a preventative. Is acetazolamide also used as a preventative, or is that particularly just during an event?
So for Verapamil, for people that use it preventatively, it partially depends on how high a dose they're on, whether I will recommend cardiology, or of course, if they had if there is some cardiac underlying problem with the heart or reason they followed with a heart doctor, I usually will consult that person before starting that medication, as well as for guidance as far as need for follow-up. If they don't have any history of a heart problem, and I'm using lower range dosing for the medication, I don't always traditionally make them follow with a heart doctor, but sometimes you may need a higher dose of the medication. And so at a certain point, there is some recommendation for screening with serial EKGs and following certain markers on the EKG, which I will usually have a heart doctor follow with me. But you often don't need that high. That's rare that you need the high dosing that we sometimes need in other conditions. So not always. I don't think you always need a heart doctor. And then the acetazolamide or the Diamox, I think both Verapamil and acetazolamide have been used as both types of treatment, both as a preventative treatment and a rescue treatment. So they both have options to be given daily to prevent attacks, as well as to be administered, in an emergent setting to try to address the attack when it comes. They're used in both ways.
Our next question is from Dr. Rotenberg. Dr. Rotenberg, would you like to turn on your mic and ask your question?
Oh, how about that? So a lot of families are using non-traditional treatments, nutritional supplements. Would you recommend caution with any of them, given that they may have interactions, or perhaps any that you've seen that families use that might be helpful?
I think that from a migraine perspective, I'm not sure exactly which ones you're referring to, but I think that people will talk about preventative supplements like magnesium, coenzyme Q10 and B2. Again, I think looking at it from when you specifically know what the genetic changes, I don't know that we've we've looked at how helpful those are. I don't know that anyone knows. So I don't know if Dr. Helbig has any other opinion. So I don't know that I would specifically recommend for people with an identified mutation. But certainly, generally, we caution anytime you're using any supplements, just because of you're not really quite sure what you're getting.
Yeah, and I would absolutely agree, Shannon. I mean, that these are usually I would say just run this by your provider. Let's just make them aware of what specific supplements we're referring to. Some supplements may have some kind of unintended consequences, especially when it comes to levels of anti-seizure medications. If a child has epilepsy as well, or is being treated in a preventative way with anti-seizure medications, most supplements, there's very little data on if they work, and we often say we neither recommend nor kind of discourage families. But I would just kind of make your provider aware.
What we're going to do is, I think we are going to go ahead and wrap up our session for right now. And we really want to thank our presenters for joining us today and for giving us all of this information.